Sleeve gastrectomy is a surgical procedure for weight loss. In this video, we will find out what is it, how does it work, who should have it, who should not have it, how is it performed, what to expect in terms of recovery, what are the commonest complications, what are the outcomes in terms of weight loss and treatment of type 2 diabetes, and how does it compare with its nearest rival, the bypass operation. Here are three cartoons of the stomach undergoing various stages of sleeve gastrectomy. Here is an intact stomach with a gutted leading to stomach, which usually has a capacity of 1.5 to 2 liters in the ducts, leading to the small bowel. On the outside of the greater curvature of the stomach are the blood vessels. The first phase, these blood vessels are detached using heat and sealing devices, followed by use of surgical stapler that then seeks to remove this part of the stomach as shown over here. The inner aspect of the stomach, and to determine the volume that has to be retained, is protected by use of a rubber bougie that is placed down the throat and then into the stomach, leading the surgeon. And this is the final finished product, where this aspect of the stomach is now removed, leaving with this section, which now converts the stomach into a sleeve gastrectomy. Has now become the commonest procedure performed in the United States for weight loss surgery. Up to 60% of all operations are now the sleeve gastrectomy. It has been approved by the American Society of Metabolic and Bariatric Surgery, primary procedure for weight loss, as well as part of a sequence of procedures for patients with very high levels of obesity. How does it work? Over here you can see a completed specimen of a gastrectomy that has converted this into a tube that I described just now. The main effect is mechanical. The volume of the stomach is reduced by between 70 to 80, thus leading to early satiety and filling. The unexpected consequence that is helpful in weight loss is reducing ghrelin. This is a chemical that is by tissue within the stomach, mainly in this part called the fundus. Ghrelin increases appetite and thus helps with weight loss. Apart from early satiety, the patients also feel that their appetite has gone down. Other chemical that helps in the process is modulation of GLP-1, glucagon-like peptide, which reduces the journey time within the stomach and increases levels of insulin. Who's candidates to undergo sleeve gastrectomy? Patients with a body mass index of greater than 40, which is calculated by height in meters squared divided by weight in kilograms. Specifically, if these patients have undergone between 3 to 6 months of multimodality intervention for weight control and have not succeeded. A lower body mass index of between 30 and 35 to 40 is reserved for those with comorbidity associated with obesity, such as type 2 diabetes, coronary artery disease, sleep apnea, and various others. Even a lower body mass index such as 30 to 35 is reserved for those with uncontrolled type 2 diabetes or metabolic syndrome. Sleeve gastrectomy can also be performed as part of a multi-procedure strategy for weight loss, specifically in patients who have a very high BMI. Sleeve gastrectomy is then followed by a duodenal switch or other such complex procedures. Sleeve gastrectomy has also been found to be relatively safe in patients with chronic liver disease and is sometimes performed for patients who are awaiting transplant to improve their outcomes and reduce risk. Who should not have a sleeve gastrectomy? Patients who are unable to undergo general anesthesia would not be candidates. Those with psychiatric illnesses that are not controlled, specifically eating disorders, should not undergo surgery, and those with coagulation disorders. Caution has to be exercised in patients with a Bariatric esophagus, the condition in which the lining of the lower gullet is altered, or those with gastroesophageal reflux. In such procedures, the surgeon may consider alternatives such as the bypass operation. All candidates for sleeve gastrectomy undergo very stringent preoperative checks that include their medical background, their mental health, previous surgery, and their anesthetic risk. All of this is performed as part of a multi-specialty practice for weight control. There is some variation in practice in terms of recovery following sleeve gastrectomy. However, most offer overnight observations, specifically for patients who have obstructive sleep apnea. Nausea is a very common symptom, and that is treated with regular medication, sometimes more than one medication to control nausea. Pain relief by use of non-steroidal anti-inflammatory medication is the norm. The attempt is made to reduce the use of narcotics and to wean off the patients as soon as possible. Initially, patients are commenced on a liquid diet, and if they can tolerate a liquid diet within 24 hours, then they may be allowed home. This is then continued for up to 2 weeks, with patients instructed to wash their tablets and so on, so that no solids are taken. Sleeve gastrectomy is generally a safe operation. Risk of dying is around 1 in 1,000. The risk of complication is approximately 5 to 7%. The reported is from 0 to 17%. Complication leading to a readmission is around 5% within the first 30 days, and about 3 out of 100 patients will require a reintervention or another procedure to treat a complication. Age has been reported as a risk factor for complications. The older adults are more at risk of developing a complication. Bleeding is a risk factor in in terms of complications, and around or up to 15% of patients may suffer this. Commonest sites for bleeding are the staple line as shown over here. This can be on the outside as well inside the stomach. Organ spleen is within the vicinity of the stomach, and sometimes that can get injured, giving rise to bleeding. And finally, because these operations are carried out through the laparoscopic route, and there are several trocars that are placed as shown over here, and any of these trocar sites that are used to perform the operation may sometimes bleed inside. The risk of bleeding is higher for older adults and those with previous comorbidities such as cardiac or renal disease. Leak is another risk factor, and this may occur between 0 to 5% of the patients, average around 3 out of 100. As you can see in this diagram over here, there is a very long staple line, and any defect along this may cause a leak to occur. These leaks are dangerous because they serve as a source of infection or a site of infection. Hence, early leaks may require a reoperation to try and find the leak and then to deal with it appropriately. It is also possible sometimes to insert a stent endoscopically and cover the site of the leak, thus reducing the risk. Once a leak occurs, it is unlikely to stop on its own because of the high pressure area within the sleeve. There's a sphincter at the top, the esophageal sphincter, and another sphincter at the bottom, the pyloric sphincter, and hence the pressure is quite high. Leaks are classified according to the timing within the first week, between week 1 and week 6 to 12 weeks, and after 12 weeks, which are chronic. As mentioned previously, the treatment would depend upon timing of the leak and the condition of the patient, ranging from immediate surgery, endoscopic treatment, or percutaneous treatment, or a revisional procedure if the leak is late. Uncommonly, a stricture may develop in the stomach tube to a waist in the stomach following the use of a bougie that is too small, or the staple line is too narrow, or there is a twist in the stomach tube. If patient is unable to tolerate a diet, initially an endoscopy is performed. The great majority of the patients will settle following that once the edema along the staple line has settled. A chronic stricture, patients usually present with symptoms that mimic reflux disease. An endoscopic assessment is useful. If patients are unable to commence a normal diet, then an endoscopic assessment combined with revisional surgery that includes opening up the top layer of the stomach called a seromyotomy, and rarely converting the sleeve gastrectomy into a Roux-en-Y gastrectomy by bringing up a loop of bowel above the stricture. In general, great majority of the patients may not require any intervention and may settle on its own or just with the help of an endoscopy. New onset reflux or worsening of existing reflux is an issue following sleeve gastrectomy, where food or stomach contents may travel back up towards the gullet. This is usually treated with medication. Sometimes it is problematic enough to consider surgical revision. The commonest procedure performed for unrelenting reflux is a Roux-en-Y gastric bypass, which deals with reflux in a much more effective manner. Patients may present between days 10 and 20 with gastric pain, that is pain in the pit of the stomach, and a CT scan may show a clot in the portal venous system. This is normally treated with medication to thin the blood for between 3 to 6 months, and rarely with surgery or direct removal of the clot within the vein to prevent more serious complication of intestinal ischemia. In terms of outcomes following a sleeve gastrectomy, the weight loss at 5 years is 60% of weight loss is maintained at 5 years, and the average BMI that is noted after the operation at 5 years is 30. In terms of treatment of type 2 diabetes, 2/3 of the patients find that their type 2 diabetes is completely resolved. It is improved in around 1/3 of the patients. It remains stable in around 30, and all of this at around 1 year after the. All other comorbidities that are associated with obesity are improved or resolved following this operation. Sleeve gastrectomy and the Roux-en-Y gastric bypass are the commonest operations performed for weight loss. In terms of how they compare to each other, it is debatable about the relative merits of each. However, in terms of weight loss, the general opinion is that the Roux-en-Y gastric bypass has a slight edge 5 years. Type 2 diabetes in several trials have been shown to be equal, whereas in some others, again, there has been a slight edge for the Roux-en-Y gastric bypass. In terms of long-term morbidity and complications, the sleeve gastrectomy has shown itself to be, in general, safer than the Roux-en-Y gastric bypass. This completes this brief video on sleeve gastrectomy. If you have any comments, please do share.